Hey everyone, it's Alisa with another step 2 question for you. Go ahead and pause this, answer it on your own, and come back and we'll do it together. A 62-year-old man is brought to the emergency department because of a sudden onset right-sided body numbness for 1 hour. He reports that he has a 15-year history of hypertension treated with hydrochlorothiazide. He is alert and oriented to time, place, and person. Neuroexam shows decreased sensation to light pinprick and temperature on the right side of his face and body. Motor strength is 5 out of 5, and deep tendon reflexes are 2+ bilaterally. Perfusion of which of the following structures is most likely impaired in this patient? So let's think about our patient. He's a middle-aged man with a history of hypertension. He presents with pure sensory symptoms. That's important to recognize. He has right body numbness and loss of temperature and pain. However, everything motor is intact. His reflexes are normal. His muscle strength is normal. So this is a where is the lesion question, which is very common on board exams. Let's go over the answer choices. The first is medial midbrain. So usually it's occlusion of the posterior cerebral artery, and the manifestations are ipsilateral oculomotor nerve palsy, so cranial nerve 3, contralateral hemiparesis, and contralateral Parkinsonism due to substantia nigra. Here's a picture of the midbrain, and here's a little bit of information. Again, cranial nerve 3 lesion, will result in the eye being down and out. And you have the corticobulbar and the corticospinal tracts affected as well. So this isn't our patient because he doesn't have any motor symptoms. The next is a posterior limb of the internal capsule. It occurs due to hemorrhage or occlusion of the lenticulostriate arteries, which supply most of the internal capsule. And as the fibers of this corticospinal tract pass down through the posterior limb, infarction leads to a pure motor stroke. And you see typically hemiparesis of the leg, arm, and the face, contralateral to the side of the lesion. So remember this, posterior limb is pure motor. Our patient has a pure sensory issue. So let's keep going. The lateral medulla. Perfusion of the lateral medulla is usually either the pica or branches of the vertebral artery. So one of these will be damaged and you get lateral medullary syndrome. aka Wallenberg syndrome, which manifests as numbness of the leg and arm contralateral to the lesion. Vestibulocerebellar symptoms such as nystagmus and vertigo and ataxia. Bulbar muscle weakness, so face. Facial paresthesia is ipsilateral to the lesion, and then dysphagia, hoarseness, and hiccups, and decreased gag reflex are very specific to posterior inferior cerebellar artery lesions as opposed to the vertebral artery. So know those. Here's a picture of the medulla and kind of what you're going to see in lateral medullary syndrome. The next is the basal pons. Hypoperfusion of the basal pons results from occlusion of the penetrating arteries, and you get this thing called dysarthria, clumsy hand syndrome. And these affected individuals present with facial weakness, dysphagia, dysarthria, and weakness of the hand ipsilateral to the lesion. You do not have sensory deficits, so this is not our patient. Subthalamic nucleus, you have presents with the classic contralateral hemibolismus, flailing arms on the side opposite to the lesion. And then ventral thalamus. Chronic hypertension and the result of lipohyalinosis of small vessels cause lacunar infarction, which include thalamic strokes. This causes a pure sensory stroke, and it includes damage to proprioception, pain, pressure, temperature, sort of like our patient. So individuals present with a one-sided numbness of the face and the body, contralateral to the affected side of the thalamus, as observed in this patient. So this is a great answer. And then parietal lobe, you see occlusion of either the ACA or the MCA. And then you will see numbness and typically paralysis. so sensory and motor symptoms. And either, depending on either it's ACA or MCA, you'll have leg, arm, or face, the classic things. And then you would also see things like parietal neglect syndrome, so aphasia, dyslexia, and then depending on which side of this, you have dressing apraxia, and you don't see that in this patient. So it's probably not the parietal lobe. So our answer is the ventral thalamus. Thalamic strokes are classically pure sensory or pure motor. And I think a great resource on this is Amboss Overview of Strokes if you want to read more. Thank you so much for doing this question with me. I hope it was helpful, and we'll see you next week.